Hello, Mavericks. Happy Tuesday. It is April 20th. We are live once again. We have another great conversation to share with you all. Wanted to do a quick intro on our event we have coming up. Kathy, I know we'll talk a little bit more about it towards the end of our episode here, but we have a collaboration in aging event coming down the pipe in September. We are so excited to be collaborating with 3 organizations to put on this event. We'll give more information as we get it. Go to our Facebook group and our Facebook page to learn more. We have a website up that you can register for. We're so excited to share that event with you all. But before we do that, I'll hand it over to the amazing Catherine Wells.
Uh-oh.
Our 2 guests.
You've been talking to Francis too much, Taylor. Be amazing. I have something I have to live up to now. Well, it's so good to see everybody. If you're watching us live, feel free to post comments. We'll get to any questions or comments throughout the show. We're really excited today to be talking about something really important, which is mental health in our older population. And we were so fortunate to stumble upon Evan, who I will have Evan and Karina introduce themselves here in a moment. But we stumbled across Evan, who focuses and specializes in this area. And especially with COVID, all of the things that our older adults were dealing with, and all of the caregivers and all of the staff. So this is a very important topic to us. So let me start by having Evan introduce himself and share a little bit of background on yourself.
Thanks so much for the introduction from an amazing co-host. I'm Evan Plys. I'm Evan Plys. I'm a licensed clinical geropsychologist at the University of Colorado School of Medicine. I'm housed in our psychiatry department. And so my background is in clinical psychology, and I've specialized in aging throughout my training. And so I work with a lot of older adult clients and caregivers and aging families. And I also do some research in this space, particularly in residential long-term care and residential post-acute care spaces around the mental health aspects and the psychological aspects of those adjustments and transitions and those major life events or sometimes life stressors.
And so geropsychologist, right?
Yes, geropsychologist.
And that's interesting because I had no idea that existed. And that really means to me that you're focused on the things that happen in the brain in the later age, which can be different than what's going on if you're in your 20s, right?
Exactly. And I think one of the important things about, specializing in aging and having that background is that, there are the neurological, the cognitive changes that happen, there are the physical changes that happen, but it's broader than that. In this developmental phase of life in older adulthood, there's different roles, different relationships, different views of society of people, and in addition to the physical and cognitive. And so I think all of those kind of create the experience of aging. And so I'm fortunate enough to have training and really understanding in that biopsychosocial, cultural lens of what it means to be in that developmental phase of life.
And I really want to point out those words, developmental stage, right? We often say older adults are towards end of life. We're working really hard on getting some vocabulary that helps all of us know that we are whole and human and live our lives all the way until we aren't anymore. And that could happen at any time for anyone. But I love that we talk about it as a developmental stage. That's great. So I hope people who are listening in, that's a takeaway. Make sure you take that one away. So Karina, tell us a little bit about you and your background.
Absolutely. Yeah. So I'm Dr. Karina Drake. So I am also on faculty at the University of Colorado School of Medicine and the Department of Psychiatry. So I'm a geriatric psychiatrist. And so what a geriatric psychiatrist is I did after finishing medical school, I did a residency in adult psychiatry. And following residency, you have the option to do additional kind of subspecialized training. So I spent a year specifically just focusing on psychiatric treatment of geriatric patients. And I've been on faculty here at University of Colorado for a year. And primarily what I do is I see patients both in an outpatient setting and also in the hospital. And this, I'm primarily focused on treating, psychiatric symptoms and issues that go along with medical problems, aging, and also cognitive disorders. So it's kind of, psychiatry, so treating common psychiatric symptoms, while also understanding some of the common other conditions that go along with older adults, such as, cognitive changes and medical issues.
That's really important. And I think about in my own experience, having doctors come and round on my parents when they were living in a senior community.
Yes.
We didn't really have a geriatric psychiatrist or psychologist to lean on. So we leaned on the family practitioner who came, who was a gerontologist.
Yes.
How do you work with those situations?
Yeah, and I think that's such an excellent point that you raised, because unfortunately, there are fewer mental health clinicians than needed, especially when we think about in the field of geriatrics. And so it is so important to collaborate with other medical specialties, people of different disciplines. So in that case in particular, I do work closely with family medicine doctors, neurologists, to make sure that we can kind of provide care from multiple different angles of different medical specialties. So, certainly not only do I see patients, but I think another big piece of what myself and also Evan, we do a lot of collaboration, which is, kind of talking in multidisciplinary teams about, patients and their specific needs, so that we make sure we're addressing things, not just from the mental health perspective, but also the medical perspective as well.
It really includes that whole person, right? When you get all of those different disciplines in there and you're focusing on the medical and the mental health. I think that's amazing.
Yeah, and I think that's such an important point, because if we see things just through one narrow lens, I think we oftentimes miss the bigger picture. Because I know, a lot of focus of my treatment is quality of life for older adults. So what can we do, not just from a mental health perspective, but also a physical perspective to optimize functioning, family interaction, cognition. And so I think that is extremely important, that we think about, the whole, not just the patient, but also the family systems, the living environment. Those are all really, really key aspects of the work that we do.
Yeah. Go ahead, Taylor.
That's incredible. And Evan, I have a question for you. So when we're talking about mental health and older adults, what are the mental health needs for older adults? What do you think those needs are?
So there's definitely a range of needs in older adulthood. Just like in most areas, older adults are a very heterogeneous group. It's a very diverse group, and even though we see typically lower rates of mental illness in older adulthood compared to other age groups, still about 1 in 5 older adults, when you include substance use disorders, have a mental illness. In my practice and as a psychologist, I often see individuals who have anxiety or depression. I think those are the most common disorders that I see. And one of the unique features of those types of mental health needs in older adulthood is that oftentimes older adults will present with what we would categorize as mild or minor depression. And I think when we use these screens and somebody comes up as having mild or minor depression or mild or minor anxiety, we might kind of brush it off as benign. But even those types of symptoms can relate to health risks, poor health behaviors, increased risk of falls, social isolation, loneliness. So it's really important to get people into treatment to see them and try to improve those symptoms, even if they are in that minor range. But those are typically the patients that I see, and I know Dr. Drake sees a different, different diagnoses than myself. I think for psychology and psychotherapy, I typically don't see people who have more than mild cognitive impairment, just because of the types of treatments that we deliver, and being in an outpatient setting as well. But when you include psychiatric illness and psychosis on top of neurocognitive disorders, which are fairly common, there's a whole other group there that can really benefit from psychiatric and mental health treatment.
Yeah, and that's interesting. And obviously COVID didn't help any of this, right? Especially in the larger communities where residents had to stay in their own room and not even, be socially isolated as well. That makes it really hard when you are dealing with depression, and how do you get someone out of depression? What have you guys seen during COVID in this area?
I think you raise a really excellent point that, of course, social isolation, decreased kind of mental stimulation, that can all worsen, both syndromes like depression, but also, cognitive difficulties. There's a little bit of, if you don't use it, you lose it. And so I do think that has had a really significant impact. And I think the other thing that's been challenging too, and unfortunately there's been, an emergence of telehealth where patients can be seen kind of through computer or other technology, but I think that can be challenging, especially for older adults. So I think that there at times have been kind of a mismatch between the resources available versus, in terms of what healthcare providers can do over a computer, and potentially what an older adult may have access to. So I think that can be kind of a unique challenge, especially as the rates of depression and anxiety have increased with the social isolation and, just kind of decreased activities and structure.
Sounds like an opportunity for improvement for us in the industry overall to bridge that gap a little bit more.
Yeah, I think that that's a really good point around telehealth. There, obviously has been this increase in that and the availability of that. And in my experience, it's been a blessing and a curse. I also work with a lot of family care partners of people with dementia, and that group, having those teletherapy services has been really beneficial, because now they don't have to find respite for somebody in order to come to an appointment. And there's also the group where there are challenges either based on internet connection or comfort with those types of technologies. And I think it's really disheartening when you're seeking mental health treatment, and we have wait lists, and there's not a lot of us who specialize in older adulthood, and you finally get into treatment, and then you have these tech issues, and it feels very hopeless sometimes. So and in facilities and communities also, you're often recruiting staff and asking them to add a different thing to their everyday tasks to set up and to facilitate the telehealth appointment. So it has opened doors, and it has also definitely contributed to some frustration as well.
Yeah, Evan, you mentioned the staff as well. I would love to jump into how we can support the staff, the whole care team, the family partners, the older adult, and the staff, the care partners and caregivers there with their mental health. Have you seen anything that we were able to support them with what you're doing?
Yeah, I think there's been this conversation has been going on for a really long time about staff in facilities, and it's, I think one of the things that's challenging is it's hard to pinpoint when the acute stress of COVID and when this like trauma is over, and now we're in this like post-traumatic phase.
Right. Right.
Oftentimes when you have these really acute stressors, it's really hard to seek treatment because people are very much in it and they're in survival mode, and also communities are rallying together, and we have equating working in a nursing home with being a hero, and that actually is protective of some of the mental health concerns that we see afterwards, like PTSD. So it's hard to know at what point do we start assessing for things like PTSD. I think right now we're just seeing a lot of burnout, a lot of just acute stress in staff, and it definitely, things like psychotherapy and building coping skills can help, and just having a break and continuing to have support from administration, I think is probably up there as far as treatments in this phase of where we are with the pandemic.
Well said.
Yeah, really great. So having the two of you really specializing in older adults, what are the benefits of having someone really just focused on that developmental phase?
I guess I can start and talk a little bit from a psychiatric perspective. What I think some of the benefits of having subspecialized training are. As part of the year fellowship I spent specializing in geriatrics, you get increased exposure to working with neurology, psychology. So I think that it allows kind of for a more integrated approach with increased consideration for medical issues that are going on, and also just kind of understanding of the different types of cognitive disorders and the symptoms that arise, and also some of the unique considerations that need to be taken into account when specific medications are prescribed to older adults. So the way I see it, it's just kind of an added expertise and kind of comfort and familiarity seeing geriatric patients with specific mental health needs. So I think that it just kind of helps broaden the understanding and experience with the patient population.
Yeah, I totally agree. I feel the same way in my field, and in psychotherapy, I really think that one of the things that really predicts success is if I can really understand and empathize with what my client's going through, and if they can trust that I can empathize and understand them, and just having that background and that education on the aging process, and navigating the healthcare system as an older adult, and those relationships, and the family dynamics that contribute as well. And I think that especially as a younger person in a position of power with an older person in a psychotherapy relationship, the fact that we have that specialized background and can understand and can empathize and can place what they're experiencing within what's normal aging, what's abnormal aging, and what are the other factors that contribute to the experience. I think it's really necessary to build that connection and trust as well.
Yeah, and I agree. Given when I tried to bring in a counselor to help my dad through some of his tough times, it's hard to find someone who really understands that and can round at those communities. And we talked a little bit about that. So tell us a little bit about your clinic and what it looks like. You guys haven't been doing this very long, correct?
Yeah, so we both joined faculty this fall, and so as part of our appointment, we got the really wonderful opportunity to start to create an outpatient geriatric psychiatry clinic, and so right now it's Evan and I. We are hopefully in the process of growing the clinic to include other providers, people from different disciplines. And so right now we both see patients 2 days a week. And so they're referred to us by other providers in the UC health system to typically neurology or geriatric medicine. And so, what I do when I see a patient is a thorough evaluation, not just in terms of psychiatric symptoms and history, but also medical history, family history, a review of the medications that they're taking, and then together, oftentimes with their families. So, collateral information from people living with the patients that I'm seeing is also very, very important in terms of treatment planning. So we, kind of all work together to create a treatment plan, which may or may not include medications, further medical workup, and then I also work very closely with Evan because I do have a lot of patients that really benefit from his expertise in terms of psychotherapy, caregiver support, and so we oftentimes, share patients in terms of making sure they have the best treatment plan possible.
Yeah, and one of the things that's been really nice about being able to set up this clinic together is when you have a mix of medication and psychotherapy, we see really strong outcomes. Both are very effective, particularly when combined. And the fact that as a psychologist, I have this really valuable resource of a trained geriatric psychiatrist who I feel very confident that these medications are going to be really tailored to older adults, and I'm going to have a really thorough background and to not have to find somebody in the community that we can trust with this specialty care. Just having that connection and having working really closely with Dr. Drake to prescribe medications, and then for myself to incorporate psychotherapy when necessary, I think has been really beneficial, and a unique thing to have both of those specialties working together. So it's been very very nice for us and hopefully for our patients as well.
Yeah, I think go ahead. Yeah, I was going to say, I think the sum is bigger than the parts, right? I think especially when we think about care for older adults, right? It does take a team, and every different disciplines bring very valuable things to the table, so that we can get that complete picture and looking at things from multiple different angles and perspectives to really provide the best care possible. So I think that's Dr. Plys and my goal, and what we're working towards.
I wanted to ask where that comes from with memory care, and if you work with anyone with mild cognitive impairment, dementia, Alzheimer's, and where those mental health needs are in relation to what you do.
Yeah, so I work with a pretty large cohort of patients with dementia, so cognitive impairments beyond just mild deficits. And I do want to kind of normalize that, especially in patients with dementia, it is extremely common that there are psychiatric symptoms that arise out of the neurologic process. So it's extremely common that patients with dementia can experience symptoms of depression, anxiety, and also psychosis. And that is just a part of the brain changes that at times patients can experience hallucinations, delusions. And so that is really a big part of what I treat are the psychiatric symptoms coming from an underlying cognitive disorder. So definitely, very prevalent and also treatable.
Right.
Because I think it can be very scary for families and patients themselves, right, when these types of symptoms arise. Because of course, I think, unfortunately, there's a lot of preconceived notions about what the word psychosis and hallucinations, and just really understanding that this is a medical phenomena coming from underlying brain changes.
Well said.
I agree. My follow-up question to that is, if I'm a family member and my loved one is going down this path of mild cognitive impairment, dementia, whatever that might be, wherever I am in that journey with them, how would I educate myself? Where would I start to try to get involved with what you are doing and get them the help that they need?
the answer. I don't know if Dr. Plys, you want to, it's up to you.
Yeah, I can. So especially for the family members, there are some really good resources online. I always send people to the National Institute on Aging has their own website. I think it's called a Alzheimer's Disease Toolkit. And there's just a lot of really, thoroughly researched scientific information in a consumable way on that website. And the Alzheimer's Association and AARP websites are equally available, and I think are really great sources as well. And I do think that seeking treatment is important too. One of the things that we don't want to see that because somebody has cognitive impairment or because with depression or something that we might attribute it to just a normal process of aging, that we're not seeking treatment. So I think it's better to seek services and then have someone say, well, I can't really do much about this, and here's why, rather than having something that's potentially treatable and then not seeking care.
And does someone need to be in the UC health system to see you, to get on your waiting list?
No, especially as we continue to grow, we would love to, see patients from all different health systems, not necessarily UC. So, both of our information, including our clinic information, is, on the University of Colorado website. And so, anybody can call and request an appointment with a referral from a provider.
Great. And we'll make sure that gets in the show notes so that people can easily find that. What you guys are doing is kind of trailblazing here. And so that's why we wanted to talk to you here on the Mavericks. So one of our questions is there anyone in your life you consider to be a Maverick, and why?
I can take this one. So I really I think one of the things that kind of got me into the field of aging was obviously having really strong relationships with my grandparents growing up, and spending a lot of time around older adults, both of my grandparents, and then visiting them in assisted living communities later on in their life. And particularly my grandmother was just a really amazing woman who for her age group and her cohort was just really strong, and actually was involved in unionizing workers in the factory that she worked in, and was just a very strong woman who was also very reserved and quiet, and just conducted herself so amazingly, and I feel very lucky to come from that lineage. And unfortunately she's no longer with me in my life, but I really do take that with me, and I just think that her strength and some of the things that she did as an advocate, and as a early feminist was really important for my family history, and something that I am very grateful to have had in my life.
That's beautiful. That's beautiful. Sort of a quiet superhero, it sounds like.
Exactly. Yeah.
Love it. Well, keep blazing trails, guys. And if people want to get a hold of you, we'll put the link to your clinic in the show notes so they can easily just go there. We really appreciate you being on the show today. And we hope to have you back in the future and maybe talk a little bit more about what you're doing as you've continued to grow. And we hope to see you at our conference in September as well. So as Taylor had mentioned, we are holding a conference, a collaboration in aging event, September 16th and 17th here in Denver, Colorado. And the goal is to create collaboration across every aspect of senior care, including our older adults themselves and their family members, because we fully believe that the only way to make really lasting positive change is to have everyone sitting around the same table, understanding each other's motivations and pain points and challenges, and then we can come together and create solutions. So that's our goal for that event. So we'd love to see you both there if you can make it. And thank you so much for joining us today. We appreciate what you're doing. Mental health is very, very important. And specifically, as we get older, things change. So having your expertise is extraordinarily valuable.
Thank you so much for having us. It was wonderful. Of course, this is a very important topic for both Dr. Plys and myself. So any and all opportunity we have to talk about it and increase awareness is much appreciated. So thank you.
Thank you for this platform. This is really great. We appreciate you both.
Thank you both. I want to echo what Kathy said. The work that you're doing is inspiring, and thank you for doing it. And thank you so much for offering it to our community. And it's wonderful to learn more and more about it every time we talk. If you'd like to learn more about our event, please go to our Facebook page or our Facebook group. We have posts there. We have a website up there. We'll also post, like we said, their website to their clinic in our show notes. You can go check them out as well. We appreciate your time today, Mavericks. We hope you have a wonderful Tuesday. We'll see you next Tuesday at the same time, same place.